Good morning, everyone. Just a couple of quick house points. First of all, in terms of a fire alarm drill, there's no drill planned for today. So if you hear the fire alarm, we go out of the building, we turn right, and we assemble at the base of the tall statue called the Duke of York statue, which is just to the right of the building. A second quick reminder. This event today is being broadcast live on the internet, so please be aware of that. Okay, so just by means of a quick introduction, for me at any rate, today's event is a continuation of the Breast Cancer Forum for this year, which is now an annual event. We did a conference last month at the Royal Society of Medicine, where the theme was international developments in breast cancer prevention and cure. And today the focus is on patient choice, various aspects of patient choice, aided and abetted, of course, by the medical community. If we put these two themes together, global medicine and patient choice, you have potentially a very powerful vision for the future. Maybe that's the perfect vision, who knows? I represent what was Pink Ribbon magazine, which I am now trying to evolve into a global lobbying organisation to help eliminate breast cancer mortality. By the year X, it's an unknown, of course, but that's the intention. I am trying to bring together three groups of people to achieve this, and these three groups of people are patients, practitioners, and politicians. And I want to thank everyone that's helped so far with the campaign, and I hope today can go some way to help defining what the next steps of our campaign might be. Just sticking to the theme of thanks for a minute, I just want to thank everybody in this room, here and now, for coming here today, as well as the people who are watching it via the Latte Lounge website online. This event is all about you. I'm absolutely blown away by the fact that we are doing this at the Royal Society, which was founded in the 1600s, and I am told is the world's oldest scientific academy in continuous existence. And finally, at the outset, I want to thank all today's speakers for their bravery in talking today about these issues that really matter to them, as well as, no doubt, offering stimulation, inspiration and clarity. So I'm now going to hand over to the next speaker with great pleasure. I can introduce Dr. Margaret Spittle, OBE, who is the clinical oncologist and chairman of Europa-Donna UK Forum. Dr. Spittle, thank you.
Hello, good morning. I am Margaret Spittle. I'm a rather elderly clinical oncologist, but I've spent many years enjoying oncology, seeing it develop, and really today's meeting is absolutely outstanding. It's going to be so wonderful. I'm really looking forward to it. The organisers have done a fantastic job in getting a different sort of group together. And I know that we'll find it extremely stimulating. My most important thing is that I now have to be able to do this. Now it says pink ribbon, which is not what I expected. And so sorry about that.
Just inch away.
Good, thank you.
Okay, take your pick from the slide.
Lovely, I'm sorry about this.
Then F5.
I know I shouldn't have done this. It's okay, we're away. Yes, so I'm the UK chairman of Europa-Donna. Europa-Donna is the breast cancer coalition in Europe, and all those Brexiteers can spit now if they want to. But it is a European organisation, and the idea was to train advocates about breast cancer, so that people who have had breast cancer or who haven't and are just extremely interested in it could have the facts, could be trained to know how to go to government committees, national committees, to try and improve the lot of patients with breast cancer. The idea is to educate, this group of people, so that they can lobby. And lobbying is the most important part, really, of what we do. Europa Donna was founded in 1993 by someone called Umberto Veronese, who will be known to you all, an Italian professor of surgery and subsequently Minister of Health. And he saw the need for this advocacy so that there could be a group of people who could be relied upon to put the case for breast cancer and with higher authorities. We were very lucky in that the first president of Europa Donna was Mrs. Gloria Freilich, who was English, and she was the founding president. And then she was followed very closely by Dr. Mary Buchanan as the president, who is here and is an endless help in everything to do with Europa Donna. And so it had a very strong initial British support from it all. And so really we run meetings in Milan, which is where our head office is, and we have staff there who set up these advocacy conferences so that we can send people from all countries in Europe to learn how to say the right things for breast cancer, how to get on the committees that actually are the movers and shakers. And so that is really what it does. I just came back from Milan, and we had a meeting of patients with advanced and metastatic breast cancer. We had 70 patients, I think. We represent sometimes something like 54 countries. Now, I know there aren't 54 countries in Europe, but then when places like Uzbekistan, etc., ask to be included, then who would say no? It was one of the most humbling meetings I've ever been to. All these ladies who are not surviving breast cancer, who are having chemotherapy, having all sorts of hormones, know that there's a dark cloud over the rest of their lives. And to hear them saying what they felt, what they wanted to do, what they wanted done, and to cooperate with other countries was really extremely humbling. So really what Europa tries to do is to bring the management, the care and the comfort of patients with breast cancer in the worst countries in Europe up to the level of the best countries. And we feel that this European organisation is extremely important in doing this. We have a stall outside, and if you would like to encourage us by belonging, it's a very, very small sum you need to pay, but we would be delighted to see you at our meetings. Well, that was all I was going to say, but now I pass over to Katie, who is the CEO of the latte lobby. Now, I know nothing about that, but I hope we will soon learn a lot about it.
I wish we were a lobby group. That's my aim. Thank you, Margaret. Thank you, everyone. I'm so delighted to be co-hosting this fantastic event on behalf of the Latte Lounge, which is, for those of you who don't know, it's an online platform for midlife women over 40 that I founded 2 years ago. We are streaming live. Hello, everyone. If you don't want to be filmed, please let us know for GDPR reasons, because we're also filming, and it's going to be later on the UCL YouTube channel, so do let us know. Thank you. I'm particularly delighted that after 50 years, well, I'm 50 next April, I'm finally able to share a platform with my dad, Professor Michael Baum, who's here today. Obviously, Dad's here to talk from a scientific point of view. My grandma died from breast cancer far too young. She suffered terribly. My Auntie Linda is also here, Dad's sister, who had breast cancer, but thankfully she's wonderfully well. And Dad spent his entire career trying to improve women's quality and length of life and ensure that no one has to suffer like my grandma did. But I am here today to represent the thousands of women who not only need and have benefited from Dad and all his colleagues' selfless work, but I'm here to help promote and present the true facts in a very simple, clear way. By being well informed, we can and should become equal partners with our doctors in making shared decisions on our treatments. And that's why today, if any of you are on Twitter and using a hashtag, we'd love you to use the hashtag Patient's Choice. This is just to help promote this conference today. So if you could just give me a couple of minutes of your time, I wanted to explain why I set up the Latte Lounge and why I wanted to support today's event. So 5 years ago, unbeknown to me, I was suffering from horrendous perimenopausal symptoms. I was very teary, cried a lot, had brain fog, I couldn't sleep, I was anxious, and I put on a lot of weight. I became a hermit and a shell of a woman, actually. I basically couldn't function properly. I had no idea what was wrong with me, and I went from doctor to doctor. Each time I was told I was suffering from depression, and I was handed a bottle of antidepressants and sent on my way. And I didn't get better. In fact, I got worse. Now, this seemed really odd to me because I've got 4 amazing kids. I've got a wonderful husband. We've been married nearly 25 years. And I was in a fabulous house, and I thought, this just doesn't add up. Luckily for me, unlike most people, I have a father who knows a bit. And I went to Dad and I said, I just don't know what's wrong with me. Dad sent me to UCH to see a colleague of his, Melanie Davis. And within half an hour, that was it, half an hour of just listening to my symptoms, she took some blood tests and she told me, you're perimenopausal. Now that was a word I'd never heard of. I'd heard of the menopause, but just thought it was for women over, 55. That was for old people. I was 40. Wasn't me. But she told me to take some HRT, and actually within a month, I felt completely better. I was like a new woman, and my husband said he had his wife back, and my kids said they had their mum back. So at this point, I turned to Facebook to see if anyone else felt this way. And lo and behold, within 2 days, I had 2,000 members. So I basically stayed up all night, hello members, approving members. And 2.5 years later, we've got 14,000 women over 40 across 69 countries. So we don't just talk about perimenopause and menopause, we are the sandwich generation. We are talking about our kids and our parents and our own health. But being my father's daughter, I wanted it to be a very safe and truthful place to be. So I set up a website, and on that website I thought it needed a medical advisory committee. So I put together this fantastic group of advisors, 3 of whom are here today, with Dr. Renee, who's our resident doctor, who will be speaking later. Dr. Louise Newson is here, and Diane Danzybrink, who is a who set up the Menopause Support Network, as well as all sorts of medics, from rheumatologists to breast cancer specialists. And they keep it a very safe space to be, and I go to them and ask for help and support if our members ask worrying questions. We're there to put up blogs which are factually correct. So really that's why I set the group up and the website, and I'm here to represent all those women, and to hopefully, by streaming live, I'm going to talk to the camera now, you guys are going to hear the real facts about all your concerns. So please send in questions to us, and I'll ask on your behalf. Anyway, that's enough from me. So I just wanted to welcome now to the stage Kirsty Lang. Kirsty, as many of you know, is one of Britain's most versatile broadcasters and journalists. She fronts the BBC Radio 4 flagship arts and culture show Front Row, and has been a former correspondent and presenter on Channel 4 News, BBC Newsnight, and the Sunday Times. So Kirsty, she's had first-hand experience, I know, of breast cancer, and is therefore very well placed to chair today's event. So please come up, and you can sit here. And we go down.
Well, thank you very much. I'm certainly looking forward to this conference. I do a lot of conferences, but I very rarely have as much at stake in the subject as I do in this one, as a former breast cancer patient and somebody who was on HRT but then had to stop it. God, I miss it. Anyway, We have a hot topic to start with, which is to screen or not to screen. That is the question. I'm very interested because my cancer was picked up on a routine NHS screening. But anyway, I know that Michael Baum certainly has a few things to say about that. But let me first of all introduce Tony Howell, Professor of Medical Oncology at the University of Manchester NHS Foundation Trust. Tony's major interests are in the prevention and treatment of breast cancer, and he's currently leading research into estimating risk of breast cancer and preventing the disease in women at high risk. And I should say we're going to have 3 speakers, and then there'll be a Q&A after the 3rd speaker. Tony.
Thanks very much, Kirsty. I need to get my talk up. So, thank you for the invitation. It's great to be in these hallowed halls at the Royal Society. The President, Ramakrishnan, has just got the Nobel Prize for defining the mechanism of the ribosome, which is the engine of life. We're dealing with things which are not quite so weighty, but for individuals they are weighty, I guess. My brief today is to say screening for breast cancer does more good than harm. I work in Manchester University NHS Trust, which is the trust where the NHS started 70 years ago, and Naren Bevan was given the keys to the NHS in a hospital in our trust. I also work in the hospital, bottom right, where tamoxifen was first used 50 years ago. It was developed at that hospital. And I also work in the bottom left, which is a very airy and lovely building, where women with breast cancer and women at risk of breast cancer are treated in Manchester. So the first thing is that I have conflicts of interest, which I think are important. I work in a breast screening centre, the largest one in the country. I direct a clinic for women with a family history of breast cancer, and they have screening at annual intervals, more so than in the National Breast Screening Programme at a younger age. And I'm involved in studies to adapt the breast screening programme to the degree of risk of breast cancer, and I'll talk about that a little bit later on. So I've got 3 parts to the talk. One is breast screening reduces deaths from breast cancer. Second, it reduces late-stage disease and extent of treatment. And the third one is the paradoxical one, which we hope to be able to reduce the amount of screening by defining risk and screening those women at high risk. So this is the good news, that the deaths from breast cancer have decreased. You can see, I don't know whether this shows on the screen. No, it doesn't. So this on the left-hand side is the death rate for 100,000 women, and this is data along here. This is the increase in deaths from breast cancer before 1988. And then after 1988, deaths have about halved. The question is why? It's great, but why has that happened? And there's a lot of debate about that. In the next slide, I show when the trials of screening were done, the randomized trials of screening were done. They were done, go back one, they were done up here, before the introduction of tamoxifen and before the introduction of multidisciplinary teams, which are also thought to help reduce the risk of breast cancer. So the trials were done here without adjuvant therapy and without multidisciplinary teams, so it gives an idea of the effect of screening by itself. I think that's very important. But, as you know, breast screening is controversial, hence this meeting today, and hence Michael talking on the other side of the motion later. And this perturbed, the controversy perturbed Michael Richards, who was then cancer czar, and also perturbed Sir Howell Kumar, who was the head of the CRUK. So they said, look, let's just have a relook at the whole of screening, and let's get the best people, but we don't want them to be associated with screening. So Sir Michael Marmot was recruited, and several other people recruited not to do the screening. Here is the statistician who sadly died earlier this year, and here's Maggie Wilcox, who represented patients in this new group, which took all the data and then tried to come to a definitive conclusion and not being swayed by one camp or the other. So this was the result of their deliberations, that screening reduces deaths from breast cancer by approximately 20%, and they estimated that 1 in 200 women should be screened for 10 years to save one life. These are the people involved, none of which are in the screening program: oncologists and statisticians and patient representatives. So they went back over the trials, and here is a picture from that paper of the trials of breast screening, which are down here. And if you, these are the point estimates of the effect. If there's no effect, all those rectangles would be on this line. If there is a beneficial effect, it would be over to the left. And if there's no beneficial effect, or worst effect, be over to the right. No beneficial effect is on the line. So you can see that most trials of randomized trials of no screening versus screening shows that there's about a 0.8 reduction, which is significant, and which is a 20% reduction in the risk of breast cancer. And that's the conclusion that the committee came to and was accepted by Mike Richards and Harpal Kumar. So that was their best estimate, and actually that estimate is similar to many other estimations of the benefits of breast screening. So in addition to tamoxifen, in addition to multidisciplinary teams, breast screening adds to the effect of the reduction in deaths from breast cancer since 1988. So in summary for this bit, thankfully, deaths from breast cancer are declining, and they seem to be continuing to decline. You can see the curve going down, as I showed you earlier. It contributes about 20% reduction, or maybe more, with better radiology and better radiologists. That's the best estimate, and it's similar to other estimates. And the effect, we think, is in addition to treatment, in addition to multidisciplinary teams. What I mean by that is that there's been more attention to detail on how to manage each particular patient, both surgically and as far as care is concerned with treatment and also personal care. So that attention to detail, we think, has helped reduce the death rate as well. So the second area I want to talk about is that the breast screening reduces late-stage disease and the need for treatment, or the extent of treatment. So here is a paper from one of the major screeners showing that, looking at the reduction in advanced breast cancer, stage 2 and above, or node-positive disease, in those trials. And here's the conclusion that, again, over to the left, there's a 20% reduction in late-stage disease. And late-stage disease, as you well know, is more difficult to treat and more likely to be fatal. So the reduction by screening in late-stage disease obviously is a benefit. Then the reduction in the extent of treatment. The old treatment.
Sorry, does anyone know what's going on in Canada? Yes.
Say again?
Does anyone know what's going on in Canada?
It was a different trial, and it was more related to breast examination than it was to mammograms. I need to get on. Yes, the Canadian trials didn't work. In a way, it's interesting to see that, and it's interesting also that you know, you can set up a trial that doesn't work, you have trials that do work, and you find, you put those in the mix, you don't ignore them. And so that was the result, even with the Canadian trials in. So in the old days, there used to be radical mastectomies. Then there was mastectomy, and now there's more women are having wide local excisions, so the breast is not removed. And the amount of radiotherapy is being reduced from the trial showing that 3 weeks was good as 5 weeks. And you'll see some developments, some interesting developments in radiotherapy later this afternoon, which is actually reducing the amount of treatment that patients need to have. There's less removal of lymph nodes because you can detect by sentinel node biopsy whether there's lymph nodes or not, and you don't need to go into the axilla so much. And the use of chemotherapy has gone down because of gene tests, and that's gone down by about 1/3 because of this. And I know that Kirsty had one of those and was, if you don't, may I say, borderline on the gene test. So you went and had chemotherapy anyway. But how far can we go to reducing the extent of treatment? If, in fact, you had a lump and it could be just treated in the clinic and it could go away and it was only a small incident in your lifetime, that would be marvellous. But at the moment, it's a big incident. We need to try and to reduce the amount of treatment. One of the problems of the, if you like, of the screening program is its detection of in situ carcinoma of the breast. That's usually shown by calcium on the mammogram. And it wasn't seen before the screening program. So you could argue that finding in situ carcinoma, which represents 20% of screen-detected cancers, is a negative. And some say, well, there is a potential for early diagnosis. And others say there's a potential for overdiagnosis. The answer is both. So one of the things is, if you think it's overdiagnosis, why don't you just leave it? You found in situ carcinoma. In situ carcinoma, the cells look cancerous, but they're bound by the cell membrane of the lobule. Hasn't broken out yet. So it's a nasty-looking lesion on the whole, but it hasn't broken out. So I just wanted to give you some data from a trial of how to treat ductal carcinoma in situ. And this trial was the UK, New Zealand and Australia trial of radiotherapy, tamoxifen and radiotherapy and surgery versus surgery alone. And in those who had surgery alone, there was a 32% risk of recurrence of the DCIS despite having surgery. And a third of those recurrences were invasive carcinoma, which potentially could metastasize and result in patient death. So even just surgery may not be enough for ductal carcinoma in situ, and it's something that you should take seriously. So the question is the estimate of overdiagnosis, because that is one of the big talking points of the screening program. And the estimates of overdiagnosis have gone all the way from 5% overdiagnosis. Overdiagnosis means that you can have a tumour there, but it's never going to do anything during your lifetime. That's overdiagnosis. And the estimates range from 5% to over 50% overdiagnosis, which is an amazing figure. It means that half the cancers are overdiagnosed. That seems actually patently absurd, if you don't mind my saying. When you do statistical adjustments to the figures, that is, looking at the lead time up to a cancer and looking at trends of incidence, the estimate comes down to about 10%, but it's still overdiagnosis. And whatever one's personal opinion about overdiagnosis, you can always find somebody who disagrees with you, and I'm sure Michael will disagree with me vehemently when he comes on the podium. But the implication is that to conclude that we're diagnosing thousands of cancers which would never progress or become symptomatic is biologically implausible. I've never seen cancer regress spontaneously in a patient. And I think that is biologically implausible. The evidence suggests that the detection treatment of DCIS is worthwhile in prevents future invasive disease, and it's estimated that about 1 breast cancer death is prevented by 10 DCIS diagnoses, and 1 breast cancer death is prevented by 5 invasive cases. And the estimates in the UK review were about 11% over diagnosis. So the implications is that the evidence suggests that the detection and treatment of DCIS is worthwhile, and it prevents future invasive disease and prevents subsequent deaths from breast cancer. But we always want more definitive evidence. The other thing is, can we reduce surgery further? And I'd just like to show you how the profession, or how oncologists and surgeons are thinking. They worry that if they leave something, it's going to be bad for the patient. So the trials are very careful. There are 3 trials in low-grade ductal carcinoma in situ, low and part of intermediate grade ductal carcinoma in situ. Those 3 trials are in the USA, UK, and the EU. And in these, quote, early lesions, the trials are not to excise the area versus excising the area to see if that is safe in this early stage DCIS. The second trial I want to bring to your attention is women over 60 with small invasive estrogen receptor positive carcinomas. The study there is excise it because you don't want to leave a cancer in situ. That's the wrong use of the word, in place. And to say, do we need radiotherapy or don't we need radiotherapy? You can see that they're trying to reduce the amount of treatment for the patient. But those are the sort of trials that are going on because people feel that they have to be very careful in the patient's interest. So in summary for this bit, screening results in smaller tumours, reduction in the extent of treatment, may lead to overdiagnosis. Leaving out treatment, as I indicated, is problematical. You say, oh, well, that's not going to cause anything. How the heck do you know it's not going to cause anything? And we don't have good markers, if you like, for bad disease, bad early disease. So we need new, careful trials, as I've outlined. Finally, can we cut down on screening? That would be great. We'd like to, ultimately one would like to eliminate the program. Ultimately we'd like to eliminate oncologists. Ultimately you'd like to eliminate surgeons, you know. The Chinese medicine was, you know, if you have somebody who gets ill, you lose your stipend from a family. So they wanted to prevent illness, and which I want to do as well. Now, we're doing a study that is called Prediction of Cancer at Screening in the screening program in Greater Manchester, which is this map here, the 10 boroughs which have got together, and we've got our own money from the government, and we've got unilateral declaration of independence in Manchester. This is great. We've got a new mayor of Greater Manchester, Andy Burnham, who's a terrific guy, and he's a great leader. I should stop all this and I get on to the... What we ask the women to do when they come to screening is to fill in a form about risk factors. Do they have a family history? Have they had a late age of first pregnancy? They also give us saliva for a DNA test to estimate breast cancer associated common genetic defects called single nucleotide polymorphisms. You can ask me to say that again, but I may get it wrong. And then we also assess breast density, because density is a major risk factor. This lady has 5 times the risk of this lady. This is a dense breast, this is a fatty breast. To get density, you have to do a mammogram. So we put all that together, and the results are here, which are somewhat encouraging. And that is, this is the percentage risk of breast cancer over 10 years. So some women have a high risk over 10 years, which in this group, it was above 8%, and it was average 12% risk over 10 years. 30 years, 36% risk. That's 1 in 3 chance of breast cancer. These are women at high risk, and so are these. That's 20% of the population. And there are women down here who have very low risk, less than 2%, 1 to 1.5%. The question is, do they need screening? What type of cancers do these women get? We've followed everybody up, and we know what sort of cancers they've developed over a period of 8 years. And the red is stage 2 cancers. These are the baddies, stage 2 plus. There are more in this group and this group than there are down here. So it looks as though the bad cancers may be at this end. That's useful to know, because if these women don't get bad cancers, you may be able to get rid of screening. They also have grade 3 cancers, more grade 3 cancers, and more estrogen receptor negative cancers. Now that's interesting, because potentially you could say don't screen these and screen these at annual intervals, for example. And there's a trial which has just started through the European Union, still there. We got a European grant, including the United Kingdom. May not be able to do that in the future, which would be an absolute disaster for British science. So here is the study. Half the women have standard screening and half the women go into this program. And these ones have no screening, these ones have, with high density, high risk, will have more screening. And that's the way that things may be going. So in summary, for risk adaptive screening, we may be able to eliminate the need for screening in 20% of women, and increase screening in the higher risk women, to focus so that we can focus on bad tumours. And I think that's very important, and Michael will, I'm sure, talk about that. The focus on density needs mammography, so we can't do this by eliminating the screening programs I think Michael wants to do. And I mentioned that the clinical trial is going on in the UK and Europe, still part of Europe despite Brexit looming. So the overall summary of my talk is that deaths from breast cancer are estimated to go down by 20% if we have a screening program, and it may be more because we have no recent trials, and that's really what we need, but we can't do them, I don't think. Late-stage breast cancer has gone down because of screening, as I illustrated. The extent of treatment for breast cancer has gone down because of screening, and because of screening, we may be able to eliminate screening in some women. So these are the people in our group. I particularly want to thank Stephen Duffy, who's a professor of cancer screening, who's helped me form my ideas. And this is our whole team of people, including my son on the top left. Michael's not the only one who has a daughter or a son involved. Very proud. We do clinics together. You don't do clinics with your father. Heaven forbid. Well, he doesn't do them anymore, but I have to tell you, I don't know if I have any time, but Michael has made the most advances in breast cancer of anybody. He introduced multidisciplinary teams, he introduced breast scan nurses, he introduced psychology into the clinic, he introduced tamoxifen, he introduced anastrozole, goes on and on. He's a visionary and a great man, even though he's my opponent. So I'd like to end by saying my take, and I've got a vested interest, but I really do believe this, that screening for breast cancer does more good than harm.